Hello, everyone. Welcome to our episode today of Brain Trust Conversations in Psychopharmacology. I'm Dr. Joe Goldberg, clinical professor of psychiatry at the Icahn School of Medicine in Mount Sinai, New York. Pleasure to welcome you to our ongoing series of casual coffee talk conversations with colleagues in psychopharmacology on topics that are, well, really front of mind, should be front of mind, and how to make them most apropos in our thinking in clinical psychopharmacology. So today I'm really honored to have a longtime friend and colleague, someone who probably needs little, if any, introduction, my friend, Dr. Roger McIntyre. I'm going to briefly introduce Roger, but I have to say, if I gave due diligence to his CV, we'd spend the whole program just going over his background. But Roger is professor of psychiatry and pharmacology at the University of Toronto, head of the mood disorders psychopharmacology unit at the University Health Network in Toronto, Canada. And he's got about another half dozen or more academic titles worldwide. He was named by Thomson Reuters in 2014 as one of the most influential scientific minds globally, has been a lead investigator, author, commentator in, I will say, countless influential articles, really across psychopharmacology, mood disorders, psychotic disorders, novel mechanisms of action. He's widely cited and regarded as someone who you want to listen to when he has things to say. So our topic for today, Roger, thanks for joining us, is going to be the role of GLP-1 agonists, glucagon-like peptide 1 agonists, and what should mental health prescribers know and understand about these drugs. So I'm going to start out by asking you that very question, Roger. How do we answer that?
Well, first of all, Joe, thanks for that intro, and always fun to do this together. We've known each other for a long time, and what I've learned in this business is certainly you meet lots of professional colleagues, but it's the personal relationships that are really quite meaningful. So it's been fun to work with you, Joe, for so long. We've learned so much together in this journey of continuing adult education, and that's the thrill of psychiatry, quite frankly, is that there's it's infinitude. You can never actually get it. We're always learning. It's fantastic. Look, this for me, Joe, this question you've posed around GLP-1s and psychiatry, like many stories, there's a once upon a time. And for me, the once upon a time starts with, well, obesity and diabetes, something I took an interest on in my career early. And what I want people to be aware of, I think most know this, is that there is, in fact, a relationship or an association between obesity and type 2 diabetes or impaired glucose tolerance and its effect on the brain. Said simply is that I often say that obesity and diabetes metastasize to the brain. And what I mean by that is that when the brain's exposed to the milieu created by obesity and impaired glucose tolerance, that jeopardizes brain health, and that manifests in different types of neurologic and psychiatric disorders. So we start with that. The second is that the GLP-1s, which were first introduced 20 years ago in 2005, have been really transformative. And transformative is a word that's so overused now, I think it's kind of lost its meaning, but they are truly transformative, what they've done in weight and glucose lowering. There's 3 additional FDA indications for those treatments. And I don't think anyone's unaware of this class of medicines. What I think has also been the case, though, Joe, is that we've now learned that independent of their effect on weight, independent of their effect on glucose lowering, they not only get into the brain, but they are affecting the brain in a way that gives us reasons to believe that they are actually psychiatric drugs. And that belief system is supported by a confluence of data, whether it be observational data, some more recent controlled trials reading out positive outcomes with respect to mental health. I think in the near term, Joe, here's the way I think about GLP-1s for us in psychiatry. On label, there's 5 indications for GLPs currently. Simply put, obesity, diabetes, sleep apnea, cardiovascular disease and obesity, kidney disease, and diabetes. All 5 of these conditions, Joe, you've written on this, I've written on this, affect people with severe mental illness more than the general population. So our patients are very much on label. There's also many off-label reasons we think about these treatments. I think about right away, Joe, trying to manage weight gain consequent to a psychiatric drug like clozapine, for example. Metformin sometimes helps those patients. It's kind of modest, quite frankly, as you know. GLP-1s are very good in helping offset some of this weight gain that we see with some of our drugs. I think a second off-label would be in some commonly encountered clinical presentations in psychiatry. such as polycystic ovarian syndrome, affects people with bipolar disorder more than the general population. So-called fatty liver affects our patients at a rate almost twice the rate of the general population. And then finally, looking at other things as well, such as binge eating disorder, which is very investigational. So in short, I think these are treatments that, frankly, started off with a kind of a psychology and psychiatry sort of authorship, so to speak. It's an interesting history behind these drugs. And then it sort of got taken by the diabetologists and the obesity people. But frankly, they are psychiatric drugs that I think are fit for purpose in the near term. And heck, I hope some of these investigations that our group and others are looking at may say these might be indicated for some type of psychiatric purpose later on.
When I was in thank you for that great concise summary. I'm thinking when I was in residency, nobody taught me or told me that there's insulin receptors in the brain, or even that insulin could have neurotrophic effects or even be relevant to mental health. If anything, it was sort of a side thing and maybe collateral damage, because as you mentioned, some of the drugs that we prescribe can cause insulin resistance and or metabolic dysregulation. And so insulin's job, right, is to bring sugar out of the bloodstream into the organs so our bodies can burn it and use it. And so I've always thought of it as collateral damage. And when if I give somebody a medicine and they gain weight and they become insulin resistant, I feel bad that I cause that, just like causing, movement disorder or sexual dysfunction. But it's really deeper than that. It really goes to part of the syndrome. I like the way you describe the metastasizing aspect. So insulin is not just something that psychiatric prescribers should think of as peripheral.
Absolutely correct, Joe. I didn't know this either. When I first started as an academic, I was, as I am now, I'm restless and I was curious about certain things. And I didn't even know at the time that in Toronto, which is my home base, the University of Toronto, way back in January of 1923, that's where the first patient ever received insulin for type 2 diabetes, a young man who was well
Banting and Best?
the Banting and Best Institute, University of Toronto. So maybe there's something in the vapor in Toronto that got me interested in insulin. I don't know what it is. I didn't even know about that fact until I got well into this. But your point's well taken. I mean, there was a famous paper about 30, 35 years ago by Skolnick and Trunick that talked about glutamate and its role in plasticity, a very famous paper. Psychiatry has really moved away from this reductive, overly simplistic notion that mental disorders are because of too little serotonin in your brain. I think we've kind of become a little less uninformed or a bit more informed, whichever way you want to put it. And that is that we talk more about plasticity. We talk about trophic processes in the brain. I would even add to that, we also talk about other things like anti-apoptotic processes and autophagy. In other words, we believe that there's something gone wrong molecularly and cellularly with respect to plasticity, trophic, brain self-repair known as autophagy, and cellular survival known as apoptosis. And when we've dug into the mechanisms of these critical molecular and cellular changes in mental illness, in postmortem brain, a variety of interesting in vivo studies, it turns out that this is a common pathophysiologic substrate. But here's where the light bulb moment happened. I had no idea, Joe, that insulin in the brain has got nothing to do with glucose utilization. In many ways, it's sort of the CEO, for lack of a better sort of metaphor, of brain plasticity. It oversees glutamate. And of course, we know glutamate well. And if you knock out the insulin receptor or knock it down, in other words, you sort of modify it so it doesn't work so well, you lose plasticity, you lose trophism, you lose normal autophagy processes and apoptotic processes. And so from an evolutionary perspective, it makes sense. Mother Nature's a pretty decent engineer. She's got this set up in such a way that insulin, which of course regulates energy in the periphery, is also regulating key molecular and cellular processes, notably for cognition and reward. And that makes a lot of evolutionary sense to me. And so we did a number of studies earlier on showing that we can engage that receptor. We used to get patients, Joe, to snort insulin in my lab. And it would not affect their peripheral glucose, but we get into their head, we could detect it with EEG, and they would get smarter. So when people have a sugar fix at 2 o'clock in the afternoon, it's not the sugar making you smarter, it's the insulin making you smarter. We've shown that through some other studies we did. But then we started sort of, it's not easy to snort insulin. It's not kind of an easy way to take a treatment. We stumbled across GLP-1 10, 15 years ago from the point of view that it could help insulin sensitization.
Mhm.
And that's how we got first interested in it, not knowing at the time that GLP-1 itself directly is affecting aspects of, neuroplasticity, the trophic processes, again, these other aspects I
Yeah.
mentioned, autophagy, apoptosis. So it's an interesting story.
So the mental health clinicians, whether you're a prescriber or collaborating with prescribers, you should be aware that sounds like insulin is doing two things. One, above the neck, it's having this neurotrophic effect. I love the way you describe this as sort of the CEO in charge of other neural systems that are
Mhm.
necessary and involved for
Absolutely.
synaptic plasticity, synaptogenesis, and basically minimizing oxidative stress and all the things
Yeah.
that we think of as final common pathways for mental illnesses of various kinds, not just
Yeah.
mood, psychosis, cognitive disorders, right? The hardware is sort of breaking up, and if we can keep it intact, we have a more functional neuropill, so to speak. So,
Right.
so if we had a way to modulate insulin with an insulin mimetic, you're saying from above the neck, the undiscovered treasure chest here is we have now a means to get into the brain and do something entirely new to our thinking when it comes to modulating neuroplasticity in the brain.
So well put. And what's interesting, science is about iteration. We're always learning. We're always learning. New information's coming out. And only in the last 5 to 10 years, Joe, it's now been revealed that on the surface of brain cells and on this, whether they be neurons and glia, there's really a trifecta. We like threes. Threes are like, we like to keep things in threes. Well, it turns out so does Mother Nature, apparently. And on the surface of the neuron, on the surface of the glia, there are three receptors that are functionally and structurally interrelated. That being the GLP-1 receptor, which is your G protein coupled receptor, the insulin receptor, and the NMDA receptor. And isn't it interesting? Because when you are subjecting the animal to stress, the animal, in fact, begins to show impairment in activity and sort of immobility. When you look at those receptors, they start, in fact, down regulating. We showed in a postmortem study in depression that GLP-1 receptor expression is decreased in depressed and psychotic people.
Mm-hmm.
Moreover, what we've learned is when you give ketamine or dextromethorphan to a patient, well, it makes their depression better. When you give ketamine or dextromethorphan to an animal who is taking a GLP, it stimulates GLP production. So NMDA and insulin and GLP, this trifecta, are all playing off each other. And they're independent. They're independent agents. They have their own job description, division of labor, but they're actually interacting with each other. So it's true that ketamine, dextromethorphan do facilitate GLP-1 signaling, and they also enhance the sensitivity of the insulin receptor in some animal models.
Now, this is fascinating. So this is the what I'll call the above the neck effects, and then below the neck, probably what most people think about is from the media. Well, these are just astounding weight loss drugs or metabolic regulators, and in my mind, that comes in two forms for the mental health clinician. One is the patient who has freestanding metabolic syndrome, obesity,
Yeah.
diabetes, and as we know, that correlates with poor mental health outcomes, functional impairment. Those of us who treat depression, psychotic disorders, bipolar disorder know that our work is especially challenging when someone happens to also have diabetes, obesity, lifestyle factors not conducive, smoking, etc., sedentary lifestyle. But the other is what probably a lot of people think of is, so do I now have an antidote for the collateral damage that I caused? And I think most people that I talk to, the first thing they think about after weight loss per se is, ooh, so should this be an antidote for iatrogenic or let's say antipsychotic induced weight gain? This is a two-part question, then I'll stop. Should this be thought of as an antidote, a go-to? You mentioned metformin before, which also can help overcome insulin resistance.
Yeah.
And then secondly, when is it the purview of the mental health prescriber to fix it the way we use VMAT2 inhibitors to fix the tardive dyskinesia we cause, as opposed to collaborating with non-psychiatric physicians? That's a two-part complicated question.
Yeah, look, for me, my view is that we have to have division of labor. Adam Smith's great phrase, the wealth of nations. Well, time is short and we're all time poor. So we have to divide the labor. Secondly, we have to stay in our lane. We have to have core competencies in what we do. That being said, is that for me, Ozempic is produced in your brain. It's produced in the nucleus tractus solitarius. I happen to be a bit selfish. I happen to think we're in the brain business, and proteins that hang out in the brain are proteins we should take interest in. That's just obviously being a bit playful on the topic, but I think when it comes to GLP-1s, I think given the fact that they're on label to treat conditions, five, that differentially affect people living with serious mental illness. That's already, oh, wait, I should be at least familiar with them. Maybe I should be
Mhm.
prescribing them. Secondly, to your point, Joe, if a patient had significant weight increase with a treatment like clozapine, and of course, of course, the first rule of the day is, well, why don't you try something else? But we often can't try something else. We have to manage the weight. And so I think GLP-1s for me are not just a treatment, but they've leapfrogged ahead, quite frankly, of metformin as my preferred go-to because of some of the other advantages that they have. And so I do think that, again, I remember when I was a medical student, it seemed like every rash in dermatology was treated with steroids. I mean, I don't know anything about treating rashes, but I don't think we need to be familiar with every single steroid, so to speak. You don't need to be familiar with every single GLP-1, but be familiar with one of them, maybe two of them, and have comfort in doing so. The other part, Joe, as well, is that you mentioned, psychotropic drug-related weight gain as an antidote. I think that's absolutely the case. And certainly, anecdotally, I have now been using these treatments in patients who have PCOS or
Hmm.
polycystic ovarian syndrome, and using them in patients who have fatty liver. And some might say, well, what's your preoccupation with fatty liver? It turns out that, our patients have very high rates of liver disease. Yes, in part because of alcohol, in part because of infectious agents, hepatitis A, B, and C. But probably the most common cause of liver disease in the psychiatric population is not those two. It may be fatty liver, actually, which can then lead to fibrosis and inflammation and so on. And I mean, God only knows what this means in terms of drug-drug interactions, the effects on cytochromes. That's a different conversation. But this is a morbidity, and this is a morbidity that can be actually helped. That's why I've been a big fan, Joe, of talking about we should be evaluating the FIB-4, the fibrosis 4
Yeah, yeah.
index. Platelets, check the AST, ALT. You can look it up on Google. People can. What is the FIB-4 to know if your patient has fibrotic liver disease? And I think we should be treating this. So I think at some point, we say, look, if you work in a rural community by yourself, the pragmatism has to drive some of this. You can't do everything. But I do think this day and age, I think given what's happening with the GLP-1s, I think that increasingly, I think the case we've made, there should be some comfort and competency in at least one or two of them.
And mechanistically, it's always seemed to me that there's a certain um, logic here that if many of our drugs cause weight gain because they cause insulin resistance, because they make it harder for
Yeah.
our bodies to burn sugar, and so the sugar goes to your liver and turns into foie gras, and then you get fatty liver, and then you get an alcoholic steatotic liver changes and fibrosis. Um, these drugs counteract the insulin resistance.
Yes.
It's actually not just like an appetite suppressant like any other. It's really going to the mechanism. It is the thing that the iatrogenic cause of the weight gain. It's going right to the mechanism of that. It's overcoming insulin resistance. Is that fair to say?
It's 100% fair to say, and you're right, it affects the insulin signaling directly. In addition, it's been shown that when you take a drug like clozapine or olanzapine,
Mhm.
it could impair directly the GLP-1 receptor. So it makes sense if you're impairing the GLP-1 receptor thanks to clozapine at all, then maybe that would be a reason to consider a GLP-1 agonist, because that's actually the receptor maybe most affected. And there's some literature on this, which is sort of interesting. So I agree with that. And I think that along with the effect on insulin sensitivity or lack thereof,
Mhm.
there's a direct effect on inflammation. This is a different conversation, inflammation, but many in the field, there's a person named Dan Drucker who's based in Toronto, and he's actually one of the, I guess, the co-authors of discovery of the GLP-1s, actually, along with some folks in New York and Copenhagen. And I think Dan Drucker's view, again, he's one of the people in the GLP-1 area, the discovery people. I think his view overly reductive, but I think he would say that he thinks inflammation is the common pathway of GLP-1s across all of these medical and psychiatric conditions. And we know that inflammation is an issue in our patients and from a pathophysiologic perspective, but absolutely the insulin impairment then triggers inflammation. And so you're getting a double, you're getting an improvement in insulin when you give it as an antidote, say to clozapine, but you're also reducing some of the inflammation.
Wow, wow. pharmacodynamically, clinically, anecdote. I have a patient who had gained weight with an atypical antipsychotic whom I put on semaglutide, and she remarked to me, her interest in food is less. She was actually kind of upset by that because food was a comfort to her. And she was saying, it's no longer a comfort. I kind of look at food. Oh, and even alcohol too is less enticing. And she was altogether thrilled about that.
Yeah. Yeah, and that's interesting. And certainly that speaks to, I guess, an aspect about these interventions, which we see now, that being that they do affect, yes, cognitive functions, but they also affect reward valence or the
Yeah,
reward,
yeah.
and so when we talk about the brain is not deciphering whether it's food, alcohol, whether it's nicotine, whether it's opioids, you name it. The brain sees that as a reward. And I think that what we've come to agree is that the pathophysiology of reward disturbances, like of just food addiction, drug addiction, alcohol addiction, smoking addiction, it's complicated, but I think it would be fair to say there's an alteration in the reward function where you have a mismatch between the reward anticipation and the reward experience. And what the GLP-1s do is they actually reduce the mismatch. In other words, yes, the exaggerated anticipatory expectation of the reward is reduced. But in most people, not all, and in most animal models, they're not eliminating the reward tone, they're reducing the reward anticipation, which is in many cases quite distressing. It's that food chatter. And for many people, it can be overwhelming and overwhelm their impulse control. So they end up involving themselves by using alcohol and drugs and food. So it's not surprising that we see a significant reduction in binge eating, in alcohol. Very nice new paper in JAMA recently showing reducing alcohol consumption and alcohol use disorder. We're seeing reductions in some illicit drugs. And we're also seeing reductions in chaotic, food intake and as well as cigarette consumption. One other aspect about this, which I think is kind of cool, Joe, because this is like totally interesting area. The GLP-1s, again, I mean, sometimes I ask, are these like, what these drugs don't do? They seem to do everything just right, which gets us, but they are certainly affecting the reward system in a way to reduce the mismatch of exaggerated anticipation versus experience. But in the case of nicotine, for example, they also can stimulate the habenula. Now, the habenula is not an area we talk a lot about in psychiatry, but we should. I call it the Debbie Downer area of the brain. When your habenula is activated, you're a miserable, downcast person. I always ask people at dinner parties, how's your habenula? And if it's really activated, I'd say, I'll talk to you later. It's just like it's really ketamine reduces overactivity in the habenula. What's interesting is that when you give GLP-1s to cigarette smoking mice, they look like James Dean, they're smoking, they got a white t-shirt on. And when they're smoking, not only does it reduce the nicotine consumption, but it stimulates aversion in the habenula. So the cigarettes are less rewarding, in fact, aversive. And that's kind of a double kind of whammy against using the cigarettes. No wonder people don't smoke as much on them and they don't gain as much weight after they stop smoking. So it's really interesting. They are absolutely affecting cognitive structures and absolutely they are affecting the reward system. The prevailing view in weight loss is that's probably the principal mode of action.
If not you or me, someone I think is going to need to write up a new kind of a psychotherapy paradigm that's based around modulation of reward, right?
Yes,
Because
absolutely.
this particular patient, it was actually quite fascinating because what she was telling me on the surface sounded like a home run success, and yet she was miffed and dismayed. And there's even a little bit of literature after gastric bypass that people that lose weight sometimes actually have a dip in mood, and some have speculated
Yes,
that it has to do with the same notion. I mean, you think I lose 10 pounds and I feel great, but the average
right.
person may not necessarily, particularly if food has taken on a salience in terms of anticipatory reward or consummatory
Yes.
reward. You've now kind of taken that away, and so there's really a transition and adaptation that they have to go through, right?
100%. Look, we want the meal to taste good. A meal should taste good. If you like an alcohol drink, that should be, appropriately rewarding.
Like appropriately rewarding, but you're talking
Appropriately
about the
rewarding.
mismatch
Correct.
because
And
it's a
so,
disorder of reward.
correct. And so what they're doing is they're recalibrating. They're
Hmm.
recalibrating the system, and that's what you want. You don't want. Now, some people will say, food tastes like cardboard now." I mean, the system's not perfect, so there's clearly going to be, I guess, an overshoot, so to speak, in some people. But that's not the way it is for most people. But for them, so Joe, you and I know we see a lot of people with bipolar disorder, and they're very often very aroused. They have a high level of arousal and vigilance. And when you reduce the pathological arousal, they often say, "I feel tired and sedated," but it's not really tired and sedation. They're just really used to being over aroused. And so you've changed the baseline. And for a lot of folks, they're just used to craving food and craving booze and craving drugs.
Sensation, novelty.
Yeah, you've reduced it. So they subjectively have to relearn that. And that can be a little bit disquieting for some people. And they may use language like, "Oh, it takes away all my pleasure." It could, but that's not usually what's happening.
No, fascinating. One or two last questions. Roger, we could talk all day, and I'm still, we're going to talk more later, but one or two last just pragmatic things. So I've heard said that in just the primary care world, um, for people with type 2 or even type 1 type 2 diabetes, you wouldn't use an insulin mimetic in a type 1, right? This would be more for the purview of type 2 because you can make insulin in type 2,
Right.
you can't use it, whereas in type 1, pancreas isn't really
Correct.
making insulin, correct?
Right. Correct.
But if someone's having end organ damage, say diabetic nephropathy, neuropathy, retinopathy, I've heard it said that primary care doctors are probably not the best person to oversee the management of diabetes. That's more the purview of an endocrinologist, diabetologist once there's end organ disease. So to your comment about lanes, and I guess collaboration as well, and splitting shouldering the workload, um, it's probably wise for the mental health practitioner to have some sense of the extent to which, if diabetes is present or prediabetes, end organs that are involved, and whether theirs will be a purely collaborative role, but an informed collaborative role, and if so, with an endocrinologist, as opposed to, I gave you clozapine or something that caused weight gain, but renal function's intact. Your ophthalmologist clears you in terms of retinopathy. There's no neuropathy. I'm in my lane at that point, prescribing a GLP-1, provided that your A1C is not in the teens and that we're not thinking about broader issues. Can you encapsulate this notion a little clearer for listeners who might be thinking, is this in my purview or not?
Yeah, and again, I'm very sensitive to this because I know a lot of colleagues in the business who work by themselves as solo operators in a small town. There's no one within, hundreds of miles in any direction. So they do everything. I think they're just superheroes, these folks, what they're doing. And I appreciate that resources are not identical in every jurisdiction. So I think we recognize that. I think the second point is that as a guiding principle, though, I do think that if you do break it, you do fix it. I've always believed that. And I think we need to be aware, what are the safety concerns and or what are the medical complications in our patients, at least be aware of it. It doesn't mean I need to manage it all. So, and I just have to know who, in fact, I can engage to help my patient as part of the circle of care. And it needs to be done thoughtfully. I just think that this is a key issue. Thirdly, is that, look, Joe, this is a new time. I mean, we've got open AI has become a big issue now in psychiatry and medicine. Just parenthetically, I've had experience now, I've written on this, where patients have showed up in our emergency room where they've had drug reactions because they went to open AI sources for guidance on how to manage their illness. And I don't think, I mean, that's the concern, but obviously there could be advantages of open AI. My point is not whether it's good or bad. My point is it's real. It's going to get bigger and bigger and bigger. And people are going to this. They're skipping Google and they're going right to these sources as ways to find decision support. And they're reading all about this GLP-1 application. So this isn't transient. This is not a pop tune on the radio. It's going to be only around for 2 months. This is going to be around for a while. This is the future. And so I think that the literacy in the public square, so to speak, as it relates to mental health, now needs to include this discussion. And I think that we just need to be familiar. But again, stay in your lane. Always, of course, practice according to your competencies. But I might also say, frankly, like a lot of things, when, I still use a lot of MAO inhibitors. I think you do as well, Joe. And a lot of people say, "Oh, no, I don't want to use those. Those are very dangerous and they're hard to use." It's like riding a bike. Once you've tried it a few times, they're not that complicated to use, actually. And I would also just say it's the same for GLP-1s. They're not that complicated actually to use. And I think once you've had a few patients, of course, maybe with guidance with a trusted colleague, I think it could very much be part of your purview. And we in psychiatry are treating so many aspects related to what you and I are talking about. I think that for many of our patients, they're going to see some outcomes that not just the patient, but the provider is going to be very pleased with.
And I second that. I would also argue that the mental health clinician brings to bear a certain insight and perspective about risks and benefits. So, for instance, clozapine is the only drug in the PDR that has the indication to reduce suicide risk in schizophrenia. It's not so easy to say, yeah, you've had metabolic syndrome, find something else to replace it with. It doesn't work that way, right? I mean, there are certain
Right.
drugs that, this is life-saving. Lithium patients who are unique lithium responders, or as you Canadians call them, excellent lithium responders, right? That's the parallel. But their creatinine starts to creep up. So if I
Right.
collaborate with a nephrologist, it's not just, may I continue the lithium? It's like, look, this is
Right.
someone who from lithium has been life-saving. Their creatinine is here, their GFR is here, their albumin creatinine ratio is here. What do you think? And it does open opportunities for real collaboration across disciplines. And I think it does allow the mental health clinician to bring to bear their insights and awareness of what this drug can do as we try to understand the risk benefit.
Absolutely. It's well put. And the future is very exciting. As you know, in the recent issue of the Psychiatry Times, we had an issue on talking about GLP-1s in the future. I'd encourage colleagues to stay tuned. Look, we have many difficult to treat conditions in psychiatry, not just weight gain from drugs, but also cognitive impairment in schizophrenia, bipolar depression, treating anhedonia, treating aspects of some of the medical problems we talked about. And GLP-1s now have moved into late phase now development in the prevention of cognitive impairment in Alzheimer's, the prevention of episodes in bipolar, depression, schizophrenia, and other things we talked about, like alcohol use disorder, smoking, and the list keeps going. So these are well along in terms of development. Fingers crossed that maybe one of these gets over the wall and is helpful. That'd be great. But in the interim, I think it has become part of our. I think it has become part of our zip code. I really do. I don't think it's sort of their zip code; it's our zip code now, and I think it's very exciting. Actually, some of these new investigations that are going on.
Wow, most indeed exciting, Roger. Well, you've given us such a wonderful overview of the present and a fascinating glimpse into the potential future. I want to call out that article you had in Psychiatric Times. It was the June issue, I believe, of Psychiatric Times.
July issue, July issue.
Yeah, issue. Okay, so we'll make sure that our listeners who want to learn
Yeah.
more can reference that on the Psychiatric Times website. I never talk with you and walk away thinking I didn't learn anything that I didn't
Oh,
know.
there.
You always, this reinforces what I know. I always come away with new thoughts and insights. So for me, it's been a real pleasure, Roger, to have you on our program today. I want to thank you for taking the time to join us, and I know our listeners are going to find this as valuable as I did. So
Thanks,
thank you
Joe.
for joining us today, and we'll see you again soon on Brain Trust Conversations in Psychopharmacology. Thank you, Roger McIntyre.
Thank you, Joe. Thanks for this. Take care, everybody.